Wonderful. So hi, everybody. I'm so glad that you can join us. And I think this afternoon's topic that we want to discuss is such an important one, where we want to talk about female sexual dysfunction and sexual pain. We as physios certainly see a lot of this in our practice where we deal with pelvic dysfunction. And I think it's a topic that a lot of people do not feel comfortable talking about or really feel ashamed about discussing their problem. And it's certainly not the normal type of topic that one will discuss at the dinner table. And, we're so comfortable saying my neck is sore, my back is sore, but we won't easily admit that we have a problem with sexual dysfunction. So I'd just like to go through a couple of things where we talk about what it is, what it presents like, and then looking from a physiotherapist perspective, how we can help somebody with this type of problem. So I'm not sure if Bettina said that to you earlier on, but if you've got questions, you're welcome to post that either in the chat or in the Q&A section, and then maybe we'll stop from time to time. I've got a couple of slides that I want to share, but maybe we can stop from time to time and see if we can answer questions in between. Bettina, so you're welcome to shout if there's anything specific or if you want to interrupt me. Great, so let's get going. So I thought I'll just give you an idea when we look at female sexual dysfunction about the definitions. And there's a lot of different definitions that we can look at, but the type that we as physios see a lot of is patients with pelvic pain. So here on this graph, you can see that basically sexual dysfunction is defined as the persistent impairment of a couple's normal or usual patterns of sexual interest and or response. So people can have a problem with arousal, with orgasm, with desire disorders, and they do overlap. But what we see a lot is that our female patients are struggling with pain. And that pain can be with penetration, pain in the vagina or the adjacent areas. And very often it's due to the tightening of the pelvic floor muscles in that area. So one of the scary things, I think, is that there's such a lot of women who actually struggles with this type of problem. And I think in South Africa, we often don't have accurate statistics because there's not that much research. So this was just some American statistics that I draw from their website, where they mentioned that 10 million American women aged between 50 to 74 will complain of different types of problems with sexual function. So it could be anything from dryness or pain or discomfort, arousal problems, or then difficulty in achieving orgasm. And that's huge. Very often, one of the statistics that we do know is that 1 in 4 women will report a pelvic floor problem. Now, pelvic floor or pelvic dysfunction problems could be either bladder or bowel or then sexual function. So it really is a big, big number of people struggling with this. And then the sad thing that we see about this is that there's often not good help available for patients. And some of the stories that we often hear is that patients will get to us and say, I've seen so many doctors, I've seen so many different types of healthcare professionals, and nobody really understood or couldn't really help me. So I think one of the nice things in South Africa is that we now have a team of medical professionals. So it's doctors, physios, psychologists, different types of healthcare professionals that are able to help somebody with a sexual dysfunction problem. And sometimes it's just about knowing who to contact and then be put on the right path, because there's certainly different types of treatments that is available. So something that I think we must make clear is that there's really a lot of myths surrounding this. And a lot of times patients come to us and they will say, I've seen the doctor and they just said, oh, you just need to relax, have a glass of wine, or maybe try some cream, or sometimes there's just not good answers and they'll say, yes, I can see that maybe your muscles are tight, but they haven't really referred them or yeah, and patients, I think, just feel quite alone, and they start thinking that, oh, this is just in my head, and maybe there's something wrong with me. So one really wants to encourage each and everybody who's got a problem that, no, it's not in your head. There is something maybe happening in your body, often surrounding the pelvic floor, that the muscles are really quite tight. And that is the problem, and that is what we need to deal with. So please be assured that when you are dealing with this, that there are help out there, and one sometimes just need to find the right path. So the two types of sexual dysfunctions with regards to pain that we often come across is dyspareunia or vaginismus. So dyspareunia basically just means that it's pain or discomfort that's associated with attempted or complete vaginal penetration, whereas vaginismus also means that it's difficult or sometimes even impossible to have penetration. So it feels like there's something blocking any attempt at inserting anything into the vagina, not only an erect penis. It could be something like a tampon or a speculum at the gynae exam. And the reason for this is because there's a lot of pelvic floor tension or tightness, or even a spasm in the pelvic floor muscles. And this then unfortunately leads to a situation where you've experienced pain when something tries to enter the vagina. So immediately that creates some fear. And next time that something comes close to you, your body is already anticipating pain, and it just makes the muscles more tight. So it becomes a vicious circle. It is important in this case to rule out that there is no structural or other physical abnormalities that might be contributing to it. But we generally see that most of the time it is actually because of the muscles of the pelvic floor being so tight. So I will show you a picture of the muscles a little bit later, and we'll talk a bit more about that. But what people are generally then experiencing is when something tries to penetrate the vagina, is that there's a burning or a stinging. Sometimes they really feel that tension in the muscles. They often describe it as a block. It feels like it can't go in, nothing wants to move, and there's a wall that I'm hitting. Sorry, that just jumped to the next slide. And some people even say that it feels like there's no opening, that my vagina is too small. You know, some of the early warning signs that might alert you to the fact that there could be a problem is if you've had difficulty with using tampons from a young age, or if your gynecological exams are really very painful, because most of the time gynae exam should not be that painful. It should be mildly uncomfortable, but when you relax, it should actually be okay. So if you're really experiencing a lot of pain, one should really think about what is happening in the area. So the two types of definitions that we see when people have got pain in this area, words that you might come across that the doctors might use, are vulvodynia and vestibulitis or vestibulodynia. So I'd just like to clarify that you know what we are talking about. And I think here it is important to understand the anatomy. You know, we tend to talk about the vagina as the whole genital space, which in fact is actually wrong. The area should actually be called the vulva. And that means it's all the external organs. So if you look at this picture from the top, the mons pubis, the labia, so the lips, the clitoris, as well as the urethral and the vaginal openings. And all of that is then really called the vulva. So the vagina is really only the muscular canal that connects the uterus to the vulva. And we tend to just talk generically and say vagina. But in reality, I think what we mean most of the time is vulva. So just keep that in your mind, you know, make sure that you are clear about that. The vestibule, so when we look at the definitions, you will see that we talk about vestibulodynia. So the vestibule, if you look on the picture, there is that tiny little area in the middle inside the labia minora. Right, so If we then look at these two definitions, what does it mean? Vulvodynia mean that it's really pain or an unpleasant sensation of the whole vulva, right from the top, from the mons pubis down over the genital area. So it could be around the clitoris, it could be in between the labia, it could be around the urethra, it could be at the vestibule. And remember that vestibule is then the area between the labia minora. And if the pain is very specifically only there, then it will be called vestibulodynia. So that's right at the entrance, and it's quite common that we see that patients who experience pain with penetration will tell you that that area at the bottom of the vaginal opening is actually quite painful. So that could be a vestibulodynia. So does this matter in terms of how we're going to treat the patient, whether you've got a vestibulodynia or a vulvodynia? No, it really doesn't. You'll see when I explain about what we as physios look at, that we are going to look at the muscle tension in the area. But it just, if you get a diagnosis from a doctor, they will often tell you that you've got primary or secondary provoked or generalized vulvodynia or vestibulodynia. So it sounds very confusing, but that's just the terminology for this. And I just thought it's important just to clarify that for you. So what we see is that as a patient or a person, you have now experienced pain with an attempt at penetration. And what is now going to happen to your body? So the first thing is that this was quite unpleasant. So the next time that you're doing the same activity, trying to have sexual intercourse, your body is anticipating pain. And that causes some fear and some anxiety, and you might see that your whole body actually becomes quite tense. And it's really an involuntary reaction. Your body is just trying to protect you. But by doing this, it now further tightens the muscles around the pelvic floor or the vagina, which is now further going to increase your pain or make the penetration even more impossible. And because you're experiencing this every time, you are feeding that negative response, which means that you are just going to experience more and more of this every time that you try and have intercourse. So you can see how it really becomes a vicious cycle, and your anxiety just actually feeds this. So eventually it's going to lead to people not wanting to have intercourse because it is so uncomfortable. And you can imagine that that really has a devastating effect on one's relationship in the end. And a lot of the time, that is what patients will say, is that my husband or my partner cannot understand that I do not want to have intercourse, and they think I'm just thinking up some or other excuse. And they don't really understand that there's actually a physical problem causing this. And I think once one understands this, and you know that this problem is not in my head, there's something physically going on in my body, you can then explain that to them. And part of our treatment also involves getting the partners to be part of the treatment so that they really can understand. A lot of time they actually have got no idea what is happening. They don't understand a woman's anatomy necessarily. So yeah, once you can get them involved and also explain to them what is happening, it can really be beneficial in treating the problem. But I think this is important, that you understand that one's fear and anxiety, because it tensions the muscles and it puts you into that defense where your muscles tighten up more, can actually make the problem worse. So a lot of times people are then, okay, so why on earth is this happening? Why do I have this pain? And I think it helps a little bit to just understand where it could be coming from. So there could be a lot of reasons for this. Obviously, some people might have anatomical abnormalities. Maybe you were born like that, or maybe you've had surgery or scars. Anything from a woman giving birth and having a tear especially if it was quite an extensive tear, could lead to pain in that area. Or if you've had any surgery around the area, anything from a hysterectomy or maybe local surgery to the vulva, or any gynecological or colorectal surgery for that matter, could be contributing to problems. Imagine if you've had cancer diagnosis and you've had radiation, that's definitely going to influence the tissues and make them more tight or less mobile. And then if one's had problems with chronic infections, so some people suffer from IBS or endometriosis or even chronic bladder infections, a chronic ongoing inflammation in the region can really cause your muscles to tension. So one must really be aware of that. And if some people really suffer for many years from that type of problem, so ongoing, it is going to cause more tension in your muscle structures, which can certainly lead to pain. Then there's also people that struggle with musculoskeletal conditions. So they might have a lot of back pain, or they might have a scoliosis, some or other asymmetry in the body. And because our pelvises are the part where we stabilize from, and that should really be able to support us when we move, if there's a problem in our muscles around the area, that can also cause tension in the pelvic floor, which will then aggravate our problems here. And then I think a really important thing to remember is that emotions and psychological causes can play a huge role. We don't realize how much our emotion, how many emotions we actually hold in our pelvic floors. As physios working in the field, we often tell our patients that, your pelvic area can be an emotional area. Just like you do this with your neck if you're uptight, you do the same thing in your pelvis if you're uptight. So you could be holding loads of tension there, and people don't realize that. You ask people, so where do you experience your pain? And they'll tell you, I can feel my neck is sore, I can feel I get a headache. They grind their teeth and clench their jaws. In the same way, you hold tension in your pelvic regions. So it can really be a big part of the problem, and it's a big part of our treatment, trying to teach people not to hold that tension in their pelvic floors. So we'll talk a little bit more about that later. And then I do think one must just mention menopause or getting older. Unfortunately, what we do see is that as there's less estrogen in the body, and we must remember that that whole area, the genital area, is estrogen rich. So the moment our hormones change, there's a lot of changes that happen in the tissue, and we can see that the tissues become atrophied. In other words, they become less mobile. They're not so plump like when you were younger. So you think about an older person's skin and how their skin develops wrinkles and their skin is not soft and smooth anymore. And the same happens to the tissues in the genital area. So that can definitely, you can imagine, contribute to dryness and more discomfort during intercourse. So that can be part of the problem that one then needs to address. What we see with most, if not all, of these problems is that because of whatever is happening in the area, whether it's scar tissue or whether it's a hormonal issue or whether there's been a nerve injury or some form of other injury maybe, that these patients often develop a pelvic floor dysfunction. So what does that mean? Let's look at that a little bit more in detail. So basically, if we say that you've got a pelvic floor dysfunction, it means that there's either too much tension in the pelvic floor. In other words, we call it hypertonic or hyperactive muscles, or there's too little tension or not enough tone, which means that it's this weak, floppy type of muscle. And both of those could contribute to a problem with pain, although it's much more likely that you will have pelvic pain when you've got too much tension. In other words, these tight muscles. Because what happens is that as your muscles become tighter, think about it, if your neck or your back is tight, there can be a spasm in the muscles, they've got increased tone, and that means that they cannot relax easily. So if you think about just a bicep muscle like this. If my muscle is tight, instead of it being able to move well, so my normal movement should be that I can contract all the way or I can relax all the way. So now this muscle is sitting here in the middle and it's like, oh, it's so tight, it can't go up very well, so it can't contract all the way, but it also can't relax all the way. And therefore, it's a hypertonic or a tight muscle that struggles to relax, and that definitely contributes to developing pain in that region. Because what we need when we try and attempt intercourse, then we want our pelvic floor muscles to be able to relax, and we want good lubrication in the area. And if this muscle is so tight, it can't do that. And that's why it feels like you're hitting a wall, because the muscles does not relax well enough to allow something entering into the vagina. So the other contributing factors, because of the muscles being so tense, we see that the blood supply to the area is less than it should be, which is immediately going to affect your ability to achieve arousal and proper lubrication. And then it starts feeling like the area is too dry and there's friction or tearing. Patients will often describe the feeling that it feels like my skin is going to tear. And the moment you experience that again, you tense up more, which makes your pain worse. So you can see how it just goes round and round. Something maybe worth mentioning is that when you've got tight pelvic floor muscles, you will often also see that people develop not only sexual dysfunction, but also a bladder or a bowel problem, whether they're constipated or they're struggling to empty their bowels, or they've got an irritated bladder or even struggling to empty their bladders. Because our pelvic floor muscles has got a wide or many different functions, anything from bladder control, bowel control, supporting the pelvic organs in the pelvis, stability around the pelvis and the spine. So when there's a problem, it could affect any of these other areas as well. And I think it's just something to consider. So when we as physios see our patients, we will look at the pelvic floor problem and treat the pain, but possibly also give advice on bowel or bladder dysfunction, because we often see that patients have got more than one problem. So we've already mentioned some of this. You can see that there's really a lot of factors that can contribute to developing tight pelvic floor muscles. And like I've said to you, emotions play a huge role. We do need to consider the tension holding patterns that we have in our bodies, because that is going to affect what happens in your pelvis and how much tension you carry in those muscles. And it's interesting when you go and have a look that some of these things can actually come from childhood, maybe from the way you were toilet trained, or avoiding using toilets at school because you didn't like the toilets. So things like that can really contribute to you developing tension in your pelvic floors. People who struggle with constipation and are always struggling on the toilet to pass a stool, they often have a lot of tightness in those muscles. And then obviously, if you've experienced things like abuse, especially if it's a physical abuse, you can imagine how big an effect that is going to have on your muscles. Especially imagine that if somebody was raped, for instance, your body is going to develop such a defensive pattern because of that, and huge tension can develop in the pelvic floor. So those can really be things that can contribute to the problem. But then we also see that other things, like even people who are athletes or dancers, because of what they were taught and how to hold their bodies upright and pull up and tighten their pelvic floors to give them a good posture, can contribute to them developing tightness because they never think about relaxing their pelvic floors. So it's quite common to see that our patients who have got pain come from a dancing background, or even people who do Pilates very regularly. And it doesn't mean that those type of exercises are bad. It simply means that you need to find the balance, that sometimes when you are exercising or dancing, you do need to hold tension in your pelvic floor to support you properly. But you then also need to be able to relax when you are not dancing or not doing the training. And people found that they've just not been taught that well, so they never think about relaxing their pelvic floors. We've mentioned how emotions can play a role. And if you are the type of person who are somewhat anxious or worry about things and get very stressed about things, and you can feel how when you get anxious, your breathing changes and your whole body almost goes into defense, the same happens with your pelvic floor. So being more anxious or more stressed and getting stressed very easily is quite a typical type of personality that we see with our patients who've got pelvic pain. And that's why we also really try and focus on teaching people how to relax and control their stresses or their anxieties so that it doesn't have such a negative effect. Because when you're consciously worried and stressed, you find that your nervous system becomes totally overactive and so upregulated. And there's a whole negative cycle that happens with the upregulated hormones, our adrenals and our cortisol levels become really very high compared to what it should be. And that puts your body into the fight or flight or freeze response, and we cannot function there. So I've got a little slide on that later. I'll show it to you again. So I think we've talked about all these various factors that can have an influence on the pelvic floor. Obviously, things like injuries. So if I fall and I break my leg, or I injure my ankle, or I fall off a bicycle, those type of injuries can obviously also have an effect on your pelvic floor. And then physical traumas, childbirth, surgeries we've mentioned, and the infections. And quite an important one is just to remember that if you've got referred pain from the surrounding muscles in the area, so typically around the pelvis, we will think about the lower back, the abdominal areas, the inner thighs, the buttocks. They often play a contributing role to why your pelvic floor muscles are tight. So, I don't know, Bettina, before we carry on, whether you actually, is there any questions that we should answer at this stage? Can we carry on? What do you suggest?
Right, I would suggest that we just take a few questions. So I think maybe you can just post some of your questions into the Q&A. Hester, if I can just comment. Sorry, I can't share my video at the moment, so sorry about that. But you know, I think what has been so valuable is to actually to go through the definitions of what all the different kind of you know, I think I've seen so many people come to me and they're so confused about what is actually going on. It's like, you know, is it this, is it that? And you know, what happens is, where do we go? We go to Google. And that can be a very scary thing. So sometimes what happens is that we have a you know, situation of a simple kind of dyspareunia, pain with sex, but someone's going and actually Googling vaginismus, and that can be scary, because sometimes all the vaginismus talk is not very positive, and it can be an extremely scary experience for someone when they read something like that. So I think it's really valuable to just understand what's happening in the area, and what's, you know, in which areas are involved, and what these words mean, because you know, we don't really understand it, and it's not like dinner, you know, dinner party conversation that we can just say, oh well, you know, let's just talk about my sexual pain, you know. So thank you for that. And the other thing that I wanted to just comment on, sorry, and you can pop your questions in while I'm chatting, but I think what is really valuable is to realize that, and I think this is where a lot of people really struggle, is that what I generally say to people is that there is never one egg in the basket. You know, there are always, and you can see there now. So people say, yeah, okay, the doctor said this is in my mind, and I've done mindfulness, I've done meditation, I've done all the mind things, I've gone to the psychologist. Or a person will say, you know, they said my hormones were not okay, and I've taken whatever I need to, and suddenly the problem's still not fixed. And I think what we need to realize is that, and also because of the almost mind-body component of it, you know, it doesn't have, like, some of it starts, yes, with a mind aspect, but you know, like a childhood trauma or something like that, where that might be the primary origin. But a lot of it isn't. It can be in the body. It can be something that's happening there that then creates that anxiety. But what happens is that it feeds. So wherever it starts, we have to look at all of the aspects that are contributing towards it. So we generally have many eggs in the basket, and people mustn't get despondent if they've only addressed one, like maybe the hormonal, or maybe the mindfulness or whatever, and think, oh, I'm never going to be fixed because you know, they said it was this and I've still got the problem. And usually there are 4 or 5 different eggs in the basket that need attention at the same time.
So true. So true.
So we do have a question. Someone's asked, saying, I normally have sharp cramp pains whenever I have sexual intercourse. Then after some time, out of the blue, I'd have an uncomfortable cramp on my right ovary. Could this be because my partner goes deeper, or it's a bad sexual position?
So I think there's different things that one needs to consider here. Obviously, from a physio perspective, what we will want to do is examine that person's pelvic floor muscles and see, can we sometimes reproduce the pain that they're feeling if we examine? Because if we can, that might mean that the pain could be from their pelvic floors. Some of it could be positional. So some people might find that if they're in a certain position, they maybe struggle to relax the muscles a little bit more, and that if they then change their position, things will be better. It could also be that they have tension in other areas, like the deep buttock muscles could be tight, or the abdominal muscles could be tight, and those type of tightness or trigger points could also cause pain that feels like pain in your ovary. So, Bettina, exactly what you were saying, there's often many eggs to consider. I think you have to physically examine a person before you can actually say yes or no. But what we very often see is, if you are able to teach somebody to relax their pelvic floor muscles more effectively, that a lot of these other pains that they feel or experience will actually be better or even disappear.
What I've noticed, just going back to, sorry, while I'm chatting, Hester, your video is not on. Maybe I'm not able to share mine, but maybe you can with yours. But going back to the bad sexual position, I think what I've noticed is that very few times, unless you're doing something very extreme, you know, it's not generally a bad sexual position, okay? But what can happen is that sometimes you may be in a position where your partner goes deeper than in another position. And what very frequently happens is that these hidden, like, tight areas in the deeper pelvic floor that are not accessed normally. And what happens is that they then trigger some pain that might not be felt in another position. And like Hester was saying, that these deeper trigger points or pelvic floor tightness spots can refer to areas of the lower abdomen, but usually it's not a sexual position problem. But obviously you are making contact with different areas of the pelvic floor with different sexual positions. So, you know, that is, but I wouldn't be worried that you are, unless you are actively doing something that you think is outrageous, but usually the body can accommodate that, you know, an erect penis in different positions, you know, so usually it's not the sexual position.
That's, yeah, no, I quite agree with that. I'm sorry, I was also just sharing my screen, so I'm just going to leave it on the slides.
That's okay. We can carry on, Hester. We don't have any more questions for now. But if while Hester's chatting, if you do have any questions, just pop them into the Q&A, more than the chat, please, just so that we don't miss them. But and yeah, let's carry on.
Right. So if we then just sort of summarize and see when we have a pelvic floor dysfunction, to remember that exactly what we've said now, there's often more than one thing going on. And that's why it's sometimes just a little bit more complicated to treat, but it doesn't mean that it is impossible to treat. And one hopes to, by dealing with all the different things that's going on, whether it's some bowel symptoms or bladder symptoms or even a prolapse, as well as pain around the area, if one deals with all of this, that we can certainly try and improve somebody's symptoms. And in case of sexual pain, our goal would obviously be to try and teach them or enable them to have pain-free sexual intercourse. That's pleasurable. That's what it's meant to be. It shouldn't be something that you are trying to avoid or really feel a lot of discomfort with. So just remember that, yes, there is a lot going on, but it's certainly something that we can help or treat. So I've mentioned this before, that when we treat this type of problem, I do think the best care is being given by a multidisciplinary team approach. And in South Africa, the team that we have got is the My Sexual Health team. And it's really, I think, such a, what's the word, a valuable place to be when you are a part of this team, not only for the patient, but also for the different practitioners. You know, and you can go and have a look at the My Sexual Health team website. It's headed up by Dr. Elna Rudolph, but they've got practices both in Gauteng, in Joburg and Pretoria, as well as the Cape. And then they do also travel to some outlying areas to see patients. But besides the actual doctors, there are psychologists, the pelvic and women's health physios. As physios, for us to work in this field, we do need specific training. It's not part of our undergrad degree, so we do need to do quite a lot of postgraduate courses to treat these type of patients. And then, depending on what's necessary, there might be social workers or dietitians or even occupational therapists as part of the team to treat a patient. And the doctors, if they come through the system and the doctors assess them, they will then be referred to the appropriate team member. So if we talk about physiotherapy and what our treatment of this is going to involve, very often the patients will be referred from the doctors if they've seen them. But sometimes we also see that patients have gone and read a little bit. They might even have Googled and come across our names. So they might land up on our doorstep first. And certainly as physios, we are able to assess the patient and look at their problems. And what's nice if you are then part of a team is that you can, if you're unhappy with anything, you can actually refer back to the doctor and say, please have a look at this. Maybe the patient's hormones need to be checked. Maybe we think there's an infection going on that needs to be treated. So it really is good to be part of that multidisciplinary team. And certainly I think the best approach to these types of problems is a holistic approach where you can really look at all aspects that needs to be seen to. As a physio, we're going to assess a patient. We ask a whole lot of questions about the various types of problems that people might experience. And once we've then done a full assessment, we will determine what the patient's goals are and what our goals would be for the patient and how we are going to treat the specific problems that we have found. So a lot depends not only on our objective examination findings, where we will look at their muscles and their posture, but also on the subjective history and considering the other problems that is present and things that could be contributing to the actual development of pain. So it is really important, I think, for this type of treatment, because it very often is quite an intimate form of treatment where we are going to be looking at their pelvic floor muscles. And we do therefore need to develop a good relationship with our patients. And I think patients need to feel really comfortable with a physiotherapist and feel that we have created a safe space where we can treat them and teach them about their pelvic floors and what to do with that. Our ultimate goal probably is we want to have pain-free intercourse, and then also less pain in their backs or their legs or their tummies or wherever else they might be experiencing pain. So a really big part of our treatment is education. I think if any of you have attended some physio, either with myself or Bettina, you will know that we talk a lot during a session, and not just talk about all sorts of things, but really talking about your pelvic floor, explaining the breathing, explaining how the muscles work, the anatomy. You need to understand how things work together. What are the different contributing factors to the development of your pain? Because we try and regulate things to a certain extent. And if you understand it better, you can really look at that better. We do want to look at posture and how posture affects your pelvic floors and the surrounding muscles, because if we don't address that tight hip flexor or tight buttock muscle, but we only look at your pelvic floor, then there's still something feeding into that pelvic floor that could be a contributing factor and why your pain is not clearing up as well as we would like to. And then the same with dealing with your bladder and your bowel issues. You know, if we don't really look at that and we don't make sure that those things are getting better as well, your pelvic floor, which is responsible for bladder and bowel control, will really struggle. Another thing that we really put a lot of attention on is that patients understand how to move their pelvic floor. So what does it mean to contract my pelvic floor? What does it mean to relax my pelvic floor? Because so often what we see is that people have got quite a poor connection to their pelvic regions, especially maybe if there's been trauma involved, and they don't really understand how to move the muscles. It's not quite as simple as just knowing how to move my arm. Now, you really need to connect a little bit and know how it feels, and especially with the relaxation, I think it's one of the most common things that I certainly hear when I treat patients is that they say, I can still feel the contraction, but I really don't know how to relax these muscles. I can't feel that at all. So it becomes a big part of our treatment to teach them how to relax their pelvic floors. So this is what we've been talking about all the time, the pelvic floor muscles. And I've just given you a couple of pictures here just so that you can see and realize it's quite a tiny muscle at the bottom opening of our pelvic areas. But it's quite a complicated area with a lot of different little muscles making up the pelvic floor. So whether it's the more superficial layer, which is around the opening, so the sphincter around the vagina and the anus, and those little triangular muscles to the side, or whether it's that deeper layer that we call the levator ani that extends right from the front around the anus and comes back to the other side again, that little hammock of muscles. And in general, it's not only one or two areas that are tight or sore, but the whole muscle group together will often be quite tight. So again, that's why we want to examine these muscles and really feel specifically, because sometimes you might find that, oh, maybe this person's right inner hip muscle is really contributing and it's very tight. Or you can actually feel that, oh, actually it's all the different muscles when you palpate them. But yeah, we try and explain that to patients in our treatment sessions. I've mentioned how important posture is, and that little picture there on the side, you can just see if my body is a bit skew and I walk funny all the time and my pelvis is rotated, or I walk skew with my foot and I pronate quite a lot, whatever the postural problem might be, that can influence your pelvic floor. You know, I think we always try and strive for perfection. Is that really right? Maybe not, but we do want to consider if there is tension or tightness in other areas of your body that it might be affecting your pelvic floor. So we will try and correct that as well. And it is important to remember that all the muscle tissues and the fascia of our bodies it's interconnected. Now, we can't separate one area from the next. So I think this next picture, okay, sorry, the next slide will show you that. What I'm showing you here is just that different referral patterns. So if I've got a tight buttock muscle, it could refer pain into my leg. The inner thigh can be a contributing factor to your pelvic floor. So these are all the muscles around the pelvis that can possibly affect your pelvic floor. So the abdominals, the buttocks, the inner thighs, the hip flexors, the iliopsoas. I'm sure you've heard us talk a lot about that. So all of these different muscles, we will have a look at that and just make sure that they're okay as well, that they're not tight or they don't have triggers that can be referring into your pelvic floor. And then this slide is just to show you that there's many different fascial lines in the body. So fascia is that tissue that on that picture on the right-hand side. It's like a continuous fibrous web of tissue that connects things and that forms support around different structures in the body, the organs, the muscle, the fatty layer. But ultimately, it connects everything together. And our fascial bodysuit, it's literally like you've got a onesie on that's connected from the top of your head to the bottom of your feet. And if you've got a tightness in one area, like my clothing, if my t-shirt is my onesie and I do this and I scrumple it up, it's going to pull me forward like that and it's going to cause an area of tension. And that is not going to affect only this area, but ultimately it will also affect how I can move my arm now. Because if this is so tight, I can't lift my arm up properly. So in our bodies, like if we've had abdominal surgery and you've got a scar there that's tight, it's going to impact what happens in your pelvic floor. So we just need to understand that. Yeah, so when we then start looking at the rehabilitation of the pelvic floor muscles, so we assume that somebody with sexual pain has got a lot of tightness in their pelvic floors, then we have to teach them how to relax those muscles. And pelvic floor exercises are typically called Kegel exercises. And I think the assumption is that all women should do loads of Kegels. In other words, they need to be very strong and they need to be able to tighten their muscles a lot. And while that might be true, it's not always the entire truth. Because if you have tight muscles, the last thing you want to go and do is hundreds of Kegels where you're just going to tighten up the muscles even more, because that's going to make your problem worse. When you've got tight muscles, you really want to learn how to relax these muscles. So we call that reverse Kegel exercises, which basically just means that we are not so much focusing on the strengthening of these muscles. If they are weak, we might strengthen, but we will do a lot of focus on lengthening the muscle or mobilizing the muscle so that they can move more normally. They need to be able to contract to give you good control, but they really need to be able to relax well enough to allow proper movement, to allow good blood supply, proper lubrication, and for us to experience good pleasure with intercourse. So sometimes I think we've got a little bit of a skewed body image and we've got this idea that a tight vagina is a good functional vagina that will give you good orgasm. And while that might sometimes be true, a tight muscle is not a functional muscle. You need movement in both directions, and that's what we want to then also try and achieve when we are rehabilitating the pelvic floor. So our physiotherapy treatment will be geared towards teaching good functional movement and relaxing the muscles where they are tight. So it will probably involve other things like stretches or other exercises. We talk a lot about down training the pelvic floor and lots of breathing. We must remember that our pelvic floor muscles are part of our core muscles. So your diaphragm is also part of your core, just like your abdominals and lower back is. So we will focus a lot on breathing, because if you do not breathe properly, you cannot move your pelvic floor in a good functional manner. So it really is important to make that part of our treatment programs. And that's just what I've said now, that we really need to understand how to breathe. And we spend a lot of time teaching patients that when they are breathing in, and I just want to give you a short explanation. So when we're breathing, if you think about your diaphragm moving, so as you breathe in and your lungs fill with air, your diaphragm is going to move downwards. So what happens in the tummy and the back and your pelvic floor when your diaphragm is moving downwards? It should expand and relax. If you have a breathing pattern where you are pulling your tummy in and tightening here when you're breathing in, how on earth can any other muscle like the tummy or the pelvic floor move with that? Because you're holding so much tension in the area. So we do need to understand how to breathe well, how to be able to do a normal relaxed pattern of breathing where your pelvic floor as well as your abdominals relax when you're breathing in. And then if you do want to teach people how to contract their pelvic floors well, we will then do that on the out breath. So in our sessions, we will spend a bit of time explaining that to people and making sure that they are able to breathe in and relax and breathe out and then tighten the muscles if they need to. But we will do a lot of breathing and relaxation and mindfulness training because people often don't connect well with their pelvic areas and they struggle with how the muscle movement feel, how it should feel when they're breathing well. Yeah, and I really think that the breathing is one of the key elements that we need to have in place. It's a cornerstone of your pelvic floor and your core stability and core strength. If you are not breathing properly, you're going to struggle with all of those things, and that really includes pelvic floor function as well. And then again, our breathing connects to our what we're experiencing and our emotions. You know, what I mentioned before, if we're getting anxious or stressed, we are not breathing properly. We've got such a tense pattern then that we are really struggling to breathe in a proper manner. So it is important to really know about the mind-body-brain connection and how that also impacts. And a lot of it comes down to understanding the breathing or about breathing and how we can utilize the breath as part of our treatment program. So that ties in with this slide where we talk about the nervous system, because if we are stressed and anxious, our nervous system is really upregulated. And that upregulated nervous system just contributes to putting us into a defense posture. So our muscles are all tight and our whole body is actually tense, which means that nothing is really working properly. So we need to take that into consideration and teach patients how to manage their stress patterns better and what they can do to downtrain their systems, not only their pelvic floor muscles, but also their nervous system. And Bettina does a lot of TRE, which is a wonderful method to help to teach your system how to be a little bit more relaxed and get rid of some of the tension. But breathing exercises and basic mindfulness can really be a huge contributing factor, and we should make that part of our treatment programs. Sometimes, if it's necessary, we do refer patients to psychologists or counselors if they need a little bit more intervention that what we as physios can offer. Not all of us is trained like Bettina as a life coach, and she does a lot of that, but not all physios are trained in providing that type of therapy for patients. So talking about relaxation, part of what we try and teach besides the breathing is encouraging people how to be a little bit more mindful about the relaxation of their pelvic floors, because you will find that somebody who carries tension, who's quite stressed, actually holds this tension in their pelvic floor muscles all day long. So even at times when they think they're relaxed, their pelvic floor is now so used to being tense and tight that it just stays in that position and it never actually relaxes. So we use different positions or visualizations or maybe movements and exercises to encourage people to become more mindful about how to relax their pelvic floors. And visualization, I think, is quite a powerful tool that we can use. If you're able to see that pelvis in your head and you see how the muscles relax or become soft, how it becomes nice and warm. You can feel, maybe imagine that the sun is shining on your pelvis or on your tummy area, and how that warm sun rays filter into the pelvis and helps the muscles to relax. Like when you're lying in the sun, you feel a little bit more relaxed. I think it helps if somebody has seen, for instance, a pelvic model, and you can show them where the muscles are, and they can imagine as they're breathing into that space that they see how their sit bones float open, or the area between the pubic symphysis in front and the coccyx at the back actually open up and relax. So all of those things are just pictures in your mind maybe that you can see and feel how the muscles relax. And a technique that I find quite useful is if you tell people to just put their middle finger on their anal opening from the outside, and then when they are breathing, you try and get them to feel how that perineum softens into their hands and gently bulges. It's not a pushing, but a gentle bulging and relaxation of the muscles. Because once you've got that, once you feel how it feels to release the tension, you can then actually start practicing that more consciously. So other things that we do as part of our physiotherapy treatment is manual therapy. So, we will do things where we treat trigger points or tension in the muscles. We will do myofascial releases. There can be a lot of manual therapy that we do, and we do the same in the pelvis. I'm sure most of you have had back or neck physio, and we will mobilize the joints and massage the muscles. And in the pelvic floor, we do a similar thing. It's a little bit different because it's an internal area that we need to work on. So it does mean that we do intimate type of treatments where we work via the vagina or even the anus sometimes, but you're basically doing an internal treatment and you're stretching or relaxing or doing a trigger point release of that specific pelvic floor muscle internally. And part of that is that, yes, you want to try and decrease the spasm of the muscle, but you also try and teach the person how it feels to then move the muscle better. So there's a lot of biofeedback. We call it biofeedback, where we try and teach people what it feels like to move the muscle better, to relax the muscle better. And that does form a big part of our treatment. And then together with the actual pelvic floor, we will treat the buttocks or the back or the inner thighs or whatever other muscles or fascial structures are tight. So this is just some example of different types of exercises that we can use. Obviously, when we treat a patient in the rooms, we will do certain techniques, but then we will send you home with exercises, positions, mindfulness, relaxation, whatever you need to go and do to facilitate your muscles or to teach your muscles how to stay relaxed. We don't want to treat you in the rooms and then you go home and next week you come back and everything is just all tight again. That's not really helpful. So home exercises are often aimed at teaching you about different relaxation positions or maybe stretches, like if your inner thighs are tight or you're tight around the hips or the tummy is tight, and you can see that these are different types of stretches that one can then introduce. People often want to know, okay, so what type of exercise is good? Is yoga good or is Pilates good? And I think it really depends. Different types of exercise programs works for different people. What you need to understand is that whatever you do, on the one hand, you do need to have good, strong muscles. On the other hand, you have to be able to relax your muscles. And if you can incorporate that balance into any exercise program, you can actually go and do whatever. It doesn't mean that one is better than the other. Maybe if you're really tight, you might find that yoga with the breathing and the relaxation is more beneficial for you than Pilates or a hectic type of training program where you're doing loads of weights or whatever. But it's about finding the balance. If you really like to do gym work and you want to exercise with weights, so maybe you might, often in the beginning we'll tell patients, let's not do that now. Let's start with the basics and we can build you up to get there. If that is what you want, then hopefully we can get you to do whatever you like so that you still enjoy your exercise program. But you do have to understand how it impacts your pelvic floor and what you then need to do with your pelvic floor to maintain good relaxation. So we've talked quite a lot about the psychological and emotional influences and how it actually affects our pelvic floors, and we've got a question on our examination form that asks, what type of personality are you? Are you that type A person that wants things like this and everything has to be in a little box? And if it doesn't, then you get all stressed and tense about things. Because yes, that is typically the type of person that will carry a lot of tension in their pelvic floors and actually not realize it. And once you make people aware of that, we then start with that down training of the pelvic floor. And I often tell my patients, go and check in with your pelvis. Stop yourself 20 times a day whether you're driving the car, whether you're sitting at the robot, whether you're standing in a queue, whether you're sitting in front of the TV, and just check in and say, where's my pelvic floor? Because if it's all up here, you really need to know then how to relax it. And we then come back to our basic breathing techniques and teaching you how to relax your pelvic floor. But yes, besides just those basic anxiety that we might need to deal with, if there are more serious problems, if somebody really have got a history of trauma or abuse, then obviously I think it's so important to deal with that. And we cannot ignore that. That type of abuse that you might have gone through, just on a physical level, could really make it much more difficult for your pelvic floor to relax. And some people really do need either counseling or psychological interventions to help them deal with those sort of things. And we often see that when working in the pelvis, that people sometimes walk out of a session and they can feel quite emotionally overwhelmed just because we've touched on such a sensitive area. And again, once they understand the link, it's sometimes easier to deal with that, but they might need some assistance. So it is important to take that into account, and whether they then need medication sometimes or counseling, hypnosis, it doesn't really matter what it is, but some type of treatment or intervention to then also help them deal with the possible trauma, or sometimes just the, whatever they have gone through. It is an important consideration. We should never forget it. This slide, I just wanted to demonstrate to you what happens with fight or flight. We've mentioned that means that your whole body is so upregulated, and we're not meant to function there. Our digestion, our lungs, our hearts, our reproductive systems cannot function when we're in fight or flight all the time. That type of response is meant to be for danger. Like if there's a lion, I'm going to run away. But the moment the lion is gone, my body needs to calm down. And we function in our parasympathetic states, where everything is more relaxed and our bodies can function well. And when we treat, that's exactly what we aim for, is to get that parasympathetic, more relaxed state of the body. And the same in the pelvic floor. It should be much more relaxed. We shouldn't have this upregulated and tightness all the time. Then there's just a couple of things I quickly want to mention. I know, Bettina, I think we're going over time. I don't know how much time people still have, but just a couple of slides that I want to talk about besides the actual physio, the other things that we also look at in terms of treatment. If there's a question, please interrupt me, but otherwise I'm going to carry on. So one of the things that's important to just consider, that if you have pain with intercourse, that a lubricant can really be helpful. So especially for those patients where they feel that they're really dry, but also just if you think about it, if there's quite a lot of tension in the muscle and you're going to use a good lubricant, it will make the movement of penetration a lot easier. So there's different types of lubes available. In South Africa, we don't have exactly all the ones that you can get overseas. They have a much better variety, but we certainly have the basic water-based lubes, and then we also have silicone-based lubes. And I think depending on the person, some people respond better to others. You do find that the silicone-based one doesn't dry out as easily and might be more comfortable for people to use. But very often, if people are okay with just using a normal water-based one, like a KY Jelly or the Diskem or Clicks type of brand, that could be absolutely fine. You do find that some people have got somewhat more sensitive skins, or they might react to a certain lube, and then you certainly want to try and suggest that they use another one if their skins are a little bit more sensitive. I think the most common ones that we get is the water-based ones. We certainly try and avoid anything with flavors or colors, like often your condom, the manufacturers of condoms, they often provide, or they make lubes as well, but they are often flavored. So we tend to say, stay away from that and just use the plain stuff. The one that we get in South Africa that is silicone-based is Astroglide, and they are generally at Diskem. You can find them. Sometimes they're out of stock. You can really only get the water-based ones. So go and have a look at what is around. on the My Sexual Health website. They also sell a lovely lube named Pure, but it is imported from overseas, so it is a little bit more expensive. But yeah, I think a lubricant can really be a helpful addition to use during intercourse, and also when we start using the dilators, which I will explain now. They're basically meant to provide relief to the dryness and reduce the friction that's caused by the tension in the tissues, or even if you've got somewhat thin tissue. So for the menopausal woman, a lube can really be very helpful. Yeah, and in the end, if you can use a lube like that, it should reduce your pain, and you should feel improvement in the sense that you should be able to also have better and easier penetration, and the movement that happens with sexual intercourse should be much easier. So go and have a look at what is available. I mentioned the dilators. So dilators are often used as part of our treatment to enable persons to not only stretch their muscles, but also be like you are desensitizing the pelvic area and trying to teach your muscles to be okay with something that's being inserted into the vagina. So there on the side, you can see there's a set of dilators. They generally come in different sizes. So the small one, the size 1, is literally the size of my finger, whereas the size 5 is a lot longer and a lot wider in diameter. So you can imagine that if you've got really tight pelvic floor muscles and the opening is quite closed, that if I struggle to get my finger in, it's going to be really difficult to insert a big dilator. But if you can start with a small one, so that it just gives a patient a tool that they can go and use at home to maintain the relaxation that we've achieved in a physio session in the rooms, but then also to create that safe space that I talked about earlier, where if you've had a lot of pain with intercourse, you are going to be quite fearful of anything that tries to go into your vaginal area. So now if you can practice in the safety of your own home, and you can start by gently inserting something, and you can help your body and your brain relax while you are doing that. It makes it a lot easier in the end to teach your body not to tighten up every time that something just comes close to you. So dilators are useful. We use them quite a lot in patients with sexual pain. And together with a lubricant, you can then really give a patient a good home program as to how they can progress at home and use the dilators. Sometimes patients bring the dilators into our rooms, and if they're a little bit hesitant or unsure, then we can insert the dilator for them or show them how to do it. But very often it is used at home. So I think it's quite helpful. We don't necessarily use it with everybody. Again, it depends on our assessment of the patient and what they can tolerate. What we generally see is that, sorry, I'm just going to go back to that slide, that once a patient have once they can insert the number 5 dilator, which is often the biggest one that we will use. There are bigger ones available if necessary, but that would often be the biggest one, that we then feel that they are physically ready to accommodate an erect penis, because it's more or less the size of an erect penis. Obviously, men differ in size as well, but I think the number 4 and 5 dilators are a general average guideline as to if you can accommodate that into your vagina, you should be able to accommodate an erect penis. So yes, we will use the dilators together with loads of relaxation and mindfulness, together with the pain education, where we explain the whole process to patients. And then eventually get the partner involved, which I think is also quite important, because if you are dealing with pain in the genital area and pain with intercourse specifically, where another person is involved, you need to be able to, as a patient, allow that other person into your space, allow that other person to insert the penis into your vagina. And if you then get your partner involved, so starting to help with the dilation, it creates that opportunity for you as a patient to relax in that space and see that this is okay, I can do this. So in that way, it's really also helpful. And I think it does help bringing the partner in. They often then can also understand better about what is going on in the person who's suffering from pain in their body. And I think that is where we then progress to the next step, which we call the penetration program, which basically means that once you are able to insert the number 5, that you're potentially ready to resume intercourse. But we don't want this whole process then to start again, that now the moment you've got intercourse, you're afraid of what you're going to experience, and then you tighten up again. So the penetration program is basically a program where you are then helping the person to tolerate penetration. And initially you literally would be like, you've now worked through using the different dilators, but then you would actually involve the partner and say, okay, so now we're going to try intercourse, but it's not what we, I think, generally expect as normal intercourse. You as a patient will take the erect penis and gently insert it into your own body, comfortable, safe, you're able to relax, and just see, can I tolerate that? Sometimes there might still be a little bit of discomfort or pain, and then you're not going to add anything more. You slowly add steps where you will eventually, if you see, okay, I can tolerate that, now maybe I will change position, or I will try and add a little bit of movement until you're able to resume normal sexual intercourse. So it's really just a program to allow you to get to a point where things are pain-free. And we explain all of that as part of our treatment sessions to patients. Yeah, and I think that sort of summarizes what we as physios can do, or how we can help you with. I think so important is that one people to realize that it's possible to treat vaginismus or dyspareunia. Now, it's not, you don't need to feel hopeless and feel that there's nothing out there and you can't be helped and it's all in your head. It is important to understand the condition, what is contributing to it, how your emotions play a role, how your exercise play a role, or whatever has happened in your past. But then to know we can treat this, we can teach your muscles how to relax, and you should be able to have pain-free, enjoyable, healthy, penetrative, am I saying that correctly? Sorry for my pronunciation. Sexual intercourse in the end. No. So I really want to encourage people, don't suffer in silence. There are people out there that can help you, whether it's the physio or the sexologist or the psychologist, but please connect, please try and find the right person, because there is really a lot that can be done to help you achieve a healthy sexual relationship that should be pain-free. There's a lot of resources out there. I've got 2 or 3 slides, so I'm sure you're all going to, we'll share the slides with you. There's books, there's websites. Please go and read the correct stuff. Don't go and just link up with anything, because there is also a lot of nonsense out there on the internet. But there is really good resources that you can go and have a look at. And yeah, if anybody has questions, or if anybody has got specific things that they want to ask, connect with us. We are available, and hopefully we can help you in some way. So I just want to say thank you for the opportunity, and I hope that I've given you some insight into what can be done. There's obviously a lot more, but hopefully this does help you a little bit with better understanding and maybe knowing more about what can be done. So thanks a lot.
Oh, Hester, thank you very much for that. I'm going to, while you guys are just having a look at Hester's sharing there, A Headache in the Pelvis is just a really amazing book.
Absolutely, no.
But there's really some lovely stuff out there, and maybe, Hester, we do have a few questions, and if you do have questions, please, now is the time. I'm sorry we are running over a little bit, but I don't want to, if you need to go, thank you for joining us, but I just want to take the time to actually go through the questions, and we can discuss a few things further. Hester, if you don't mind, just change the host for me. Sorry, I can't switch my video on, just so that's a little bit more personal as we go through some questions. But I think what is just really amazing that you've gone into it in so much detail, Hester, because I think what we sometimes, get, so detail can sometimes overwhelm us, and but I don't want any of you to feel overwhelmed by anything that Hester has shared. So like what is important is that Hester has gone through a variety of kind of treatment options and the way that we look at that. Sorry, Hester, I'm still not able to switch
I'm
my video.
trying to, yeah, I see here. I'm trying to put you on for some
Sorry
other
about
reason, I'm
this,
looking at
guys, but
your
if
little
not, don't
picture.
worry. You
Apologies for
stay.
this.
You stay on. It's fine. But really, I think what is really important is especially in these conditions where we don't like whatever, we don't want to talk about things, we don't want to discuss anything, it is important to have the correct information. Hester, I can't see it all now, so don't worry. Stay where
Oh,
you
goodness.
were.
Okay, let me go
um
to the previous one.
so, yeah, thank you for the detail, but I also want to just reiterate that if you are looking at this and thinking, oh my word, if I have to go to a physio, I'm going to have to do this, I'm going to have to do that, this is what they're going to do, this is what they're going to take me through, they're going to do an intern examination, and I'm scared of that, so I don't want to go and see anyone, or they're going to make me do dilators because that's how we treat this. I want you to really realize, so Hester, I can't see you again. So what I just really want you to realize is that these are ways in which they're different. There are many roads to Rome. We assess each of you on an individual capacity. So let's say you have very severe vaginismus. So again, looking at vaginismus specifically versus any of the other labels in a way, vaginismus tends to be the more severe forms of kind of pelvic pain. But I want you to realize that if you do have these feelings like, I can't have anyone touching me, I'm too scared to be examined, I don't even want to take my clothes off, I want you to realize that you can still come and make an appointment to see us or anyone else.
Right.
We are not going to force an examination on you. We're not going to force you to, kind of, and this is where, I also tend to work more mind body. I do have a master's life coach certificate, and I do work a little bit differently to I've stepped out of the typical physio box a little bit, where sometimes it allows me through other modalities like TRE to start accessing that area, to start getting that area to relax, and by not actually touching and exposing. And so although that is in a way the way that we would go about looking at actually treating these conditions, just remember that if you are not there, that's also okay. You don't have to and sometimes what happens is, the body does its own kind of reactive protective mechanisms. So even if your brain thinks, I'm okay to have someone examine, or even just for us to look, or start with basic touch, your body might go into quite a strong reaction going, no. And we're not going to force through that. Part of what we're here to do is we are here to help you start to understand your body's relationship with that area, to start to understand what your body does, because maybe you don't even realize that your body just almost goes into a complete spasm at just the thought of it. And sometimes it's not even, we'll have a set of dilators, but we're not even intending to use it initially. It's just the trigger. So sometimes you'll just see that first dilator and the body goes, oh, I can't do that. And we'll help you. We'll help you work through those emotions, through that kind of mind-body reaction to get you over that. So don't feel that if you are in that space where you are overwhelmed with taking, with all these treatments that Hester spoke about, that you go, oh, I'm not ready for that, I can't do that. Hester can spend, or both of us can spend a large amount of time not even near the pelvic floor. And this is what was so great, Hester, when you shared that slide about all the different trigger points and all of that, because you spend a lot of time doing all of that beforehand. I might kind of do slightly different. I have a tool bag in my more life coaching side, so I'll also approach things kind of more on slightly different. But what I'm trying to say to you is that you can definitely still
There's a lot
ask
that
for
one
help.
can do now.
Yeah.
Outside or whatever, you don't just have to deal with the pelvic floor. Ultimately, you probably do, but there's a lot that you can do outside of that to also help the condition.
And I think the other thing that we need to just and you did mention it, and I just want to reiterate what you were sharing there, is that we have different types of sexual dysfunctions, and pain is not the only one. So
That's correct.
So we tend to think that okay, I don't have pain, so I don't have in inverted commas problem, and I can't get help. But sometimes you may find that you struggle to orgasm, you can't reach an orgasm, or you don't have libido, or there are various other kind of associated things that can cause a one to not enjoy the sexual space, and I think really part of what we're here to do, and together with the team, is to really aid you guys in having a good sexual experience, and whatever that means for you in in your sexual preference or experience, or expectation. Some women don't have an expectation to orgasm. It's not a priority for them, but penetration is. For another woman, it's like, no, I want to orgasm. So it really is all about you. It's not about us, and it's not about what we think, But yeah, so thank you for that. Is there anyone else that would like to ask anything? So the other thing that I wanted to just comment on is that I think what you were sharing, Hester, was so valuable again in its kind of depth, was that we need to assess. So it's not like this, and maybe you want to elaborate on that, because I think a lot of people it's like this box, I have this thing, whereas really what happens is that there can be a myriad of different reasons why you're having the problem, and just because you think it might be the one thing or the other thing, really what we need to do is assess. And based on the assessment, we can then build a treatment plan according to you, according to what you're struggling with. And sometimes once we've done that, I don't know if you have the same experience, Esther, but sometimes someone will say, I'm not ready for that. And that's okay. It's okay that you're not ready. And maybe to start treatment when you are ready, but assessment is important, because then you know what you're dealing with. And maybe you can elaborate on that, Hester.
Yeah, I agree absolutely with what you're saying, is that each person is different. And although you might come in with pain around the vagina when you struggle with penetration, there's often such a lot more going on. Like you said, there's often so many eggs in the basket. And as you treat and as you go on, you will maybe realize that, okay, this might play a role. Your posture, or the way you exercise, or the chronic inflammation that you have in your bladder, or whatever, can really contribute, and one needs to deal with that as well. So there's such a lot of stuff going on that we just need to look at all the time when we are treating. And I like what you were saying about, if you come in as a patient, some days a person will walk in and say, I cannot tolerate any internal work today. And that's okay. There's often such a lot of other things that we can do, because it's not only one problem, or it's a multifactorial thing. So we deal with whatever you present with. And we build on that every time when we see people trying to progress slowly, so that you can get to a point where you have a better understanding of your muscles. And sometimes you might find that people are okay, I've done quite a lot and I don't feel that I'm ready to do more now, and they might go, and you might not see them for a month or 2 or 3 months, and then they might come back and say, you know what, I've had to deal with that emotional problem, or I saw the psychologist, or I did some life coaching or theory or whatever, and now I'm actually ready to do more again on a physical level. So it depends. Now there's such a lot going on, and such a lot of things that we really need to look at. And I think our physical examination, not only the physical, it's actually both the subjective and the objective. There's a lot of things going on that we need to consider. And that's why we spend such a lot of time on that. So I don't know if there's any more specific questions regarding that. People are welcome to ask.
Yeah, so I think also on the back of that, just because there's a lot going on, it can also be quite simple. So like we don't
Yes,
have to,
yes,
you don't have to also
no,
think that oh
absolutely.
my word, like I wonder like what is all going on here. And that is why an assessment is so valuable, because sometimes
Mm,
really it's as simple as
yes,
kind of a few exercises, an internal examination, and someone will honestly say, wow, I cannot believe that I've had this problem for how many years, and in one
absolutely.
session or 2 sessions this has been resolved. And this is where
And
the
they start
team
to
also, yeah, the team comes in, and there is a comment about the value of the multidisciplinary team, and how we just like want to encourage women to be patient. So sometimes it does take time to address all the like different things that come up, and that's absolutely true, is that if you do have a couple of things that are interplaying, that it can take a bit of time, and that's okay, that, but at least you're moving forward, at least you're not stuck in that box of no one can help me, nothing's making me better. And I think the reality of something related to sexual dysfunction is that it's not only about us, as women,
yeah,
it is about a partner as well. And
yes,
that gets tricky because we feel, from the emotional side, I know that a lot of women feel really inadequate, not good enough. They feel like they're
mm,
disappointing their partners, and this is where it's so great to be able to actually bring the partner into the mix, because then both of you feel like you're making headway, and then it's almost like, even if it's not perfect or you're not where you want to be, at least both of you can see that there's a way forward, and everyone's on the same page. So
yeah.
yeah.
No, absolutely. I agree with that fully.
Okay, there don't seem to be any other questions, if
Any
anyone
more
has
questions?
anything else. So really, sorry, there actually was one other question earlier, that if a lady was asking if she wanted to come and see us, where would she be able to reach you? So Hester did put up a slide with her contact details. Otherwise, what you can do is you can just go, if you're not on my mailing list, you can go to bettinamoser.co.za, and what you can do is you can either make an inquiry through my website, and if you specifically want to see one or the other, so if you specifically want to see Hester, just say, Hester and I are in the practice together, so you can just ask for Hester there and I'll put you on to her. um, if you are interested in kind of some other stuff that we're doing, just you can give us your details as to the newsletter, and then we will inform you of other talks and stuff that is happening. So I run a meditation at the moment. It was running this year on Tuesday at 5 o'clock. And I specifically have done that to assist people in that process of helping to regulate their nervous system, to calm. We do breathing work. So all of that relaxation, that can be really difficult to do alone. So what I do is I just provide that space. We're about half an hour, generally most days, and I'll send the links out for it in the new year. But you're more than welcome. It's for free. You're more than welcome to come and join me. And we run through a bit of a mindfulness or meditation. So it's not kind of, we don't do kind of funny things. We just tap into the body, or we do imagery and we do breathing work. So you're welcome to join us there. And there are also various other things. I run an online TRE, which is tension and trauma release, which sometimes can be a great added benefit to the manual therapy or the hands-on work, because it just calms the system down. And if the system is calmer, then,
It
kind
really
of,
makes a difference.
yeah. So
Really
if you are
does.
interested in getting more information about that, you're welcome to just pop onto my website, bettinamoser.co.za, and just either send us an inquiry or otherwise just give us your details for the newsletter. I have a question: when is the TRE course? So I do, there are various things that will come out in the new year. We are now kind of November, so in January I will put out some other stuff. So at the moment, the online TRE is running on a Thursday morning at 9 o'clock. I'm not sure if it'll be the same day, but I think it might stay there. And I have a few other kind of programs that I may put out in the new year. So, but again, the best thing is just to get onto the mailing list, and we can give you all the details there, and you can jump in or out as and when it suits you. But Hester, I just wanted to take this opportunity to really, really thank you for this. Your expertise and your value here is really amazing. And thanks for your time and for all the information that you've shared. And I'm going to say thank you from my side. I don't know if there's anything else that you'd like to share.
Specifically at this point in time, yeah, just encouraging people to connect with us if you do feel that you need a little bit more support. So thanks again.
Thank you so much, and thank you all for joining us. And we will be back with these discussions in January. So I hope you have just a really wonderful December. Happy holidays. It's been a tough 2020. So rest, relax, enjoy, and we'll hopefully see you in some or other form in January.
Absolutely.
Okay, good then. Lots of love.
Thank you.
All right.
Keep well. Bye-bye.
Bye-bye.